All right, so drawing that venipuncture. So all blood collection procedures will begin with a request for a test from the physician. That request is going to come through on a requisition. So either it's going to be electronic or sometimes paper still. On that requisition, there is some minimum information that must be on it. That includes the patient demographics, such as the patient's full name, their date of birth, their sex, and their race. For inpatients, it may be a little different as they may have their hospital ID number, room and bed number as well. So you have to have at least 2 identifiers. Room and bed are generally not going to be a patient identifier. That's just going to help you find the patient. So for inpatients, you would have a hospital ID and their name and maybe their date of birth, and that's how you can ID those patients. You also need to have the name or code of the physician that is ordering the test. You need to have the test that the physician wants to be ordered. And then you need to have the test status, which is if they need it stat, so they need it now, or if they want it timed, let's say they want it at noon, or if they want the patient to be fasting. The physician must also provide the International Classification of Diseases code, which is the ICD-10 code. The number and type of tubes to collect may also be indicated on the requisition. Test names may be abbreviated, so it's important to know the meaning of those test abbreviations. So an example of that would be a CBC. I know we've mentioned that before, and that's short for complete blood count. The purpose of the requisition helps to allow you to identify the patient correctly and also may provide you with some helpful information, such as if the patient needs to be fasting. It tells you what specimens should be collected and allows you to gather necessary equipment for the collection before the patient even comes in your room. So the requisition itself may not indicate the special handling procedures, and you may be required to consult laboratory resources to ensure both correct collection and correct handling of the samples. All right, so there are the steps of a routine venipuncture. If you look in your textbook at procedure 9.1, it outlines it for you very nicely. But the first step is to greet and identify the patient. So again, you're going to greet the patient, and then you're going to use 2 patient identifiers. So, hi, I am Stephanie from the lab. I'm here to draw your blood. Can I get your name and date of birth, please? That would be, a greeting, and then you can identify the patient that way as well once they give you your name and date of birth, and it matches up with the requisition that you have. Then you're going to position and prepare the patient. You're going to perform hand hygiene and put on gloves. You're going to apply the tourniquet, select the site, palpate the vein, clean the site. You're going to assemble your equipment. You're going to reapply the tourniquet, and then you are going to examine the needle to make sure it looks the way it should. And then you're going to perform the venipuncture. You're going to fill the first tube, advance and change the tubes if needed. You're going to remove that tourniquet, and then you're going to prepare for needle removal. You're going to withdraw that needle, and you're going to dispose of the entire used needle collection system in the sharps collection container. You're going to label the tubes with the patient still in the room. Lots of times they want you to also have the patient look at the labels on the tube as well to verify that that is them. You're going to attend to the patient, see if they need anything else, and then you're going to deliver the specimen to the laboratory. For inpatient requisitions, you're going to examine them to make sure it has the necessary information that is needed, such as the patient's full name, date of birth, the ordering physician, and where the patient is located. So if they're in the emergency department or if they're in room 302, you're going to check for duplicates. Sometimes that happens if they have multiple physicians tending to them. They may have, a CBC ordered now, and they may have one 15 minutes from now. So you're going to check for duplicates. You're going to prioritize the requisitions. Stat is always going to be first because that is immediate. They need that now. Time collections, usually they need to be drawn within 15 to 30 minutes of that time. So if it says noon, you need to get there as close to noon as you can to draw that. If it's routine, you're going to follow your facility's protocols on what they state for routine. You're going to collect all the equipment you will need for the collections you are performing. Advanced Beneficiary Notice of Non-Coverage. So this is known as an ABN, which is also known as a waiver of liability. So sometimes a patient's covered by Medicare. It may request a service that is not eligible for reimbursement. So patients must sign the ABN or the Advanced Beneficiary Notice, and it shows that the patient understands that the service may not be reimbursed, and that just basically shows that the patient would be responsible for the charges. It must be presented to patient far enough in advance of service. So lots of times, especially in an outpatient type setting, you would give it to them, when they come back for their blood draw. And if you've been given an ABN for a patient, it's important to obtain the patient's signature on the form before providing the service. Patient identification. So correctly identifying the patient is the most important step of any phlebotomy procedure. Even if no harm comes to the patient, drawing blood from the wrong patient could result in dismissal of the phlebotomist and the potential for a lawsuit. All inpatients should be wearing an ID band that's issued by the hospital, so that is a good way to check their two identifications. If the patient is able to talk, that's another way as well. Talk to them, check their wristband. If they're outpatients, lots of times they will not be wearing a wristband, and that is when you're going to have to ask them their name and date of birth. When blood is drawn from the wrong patient, the test results for that blood will be attributed to the wrong person. This could have profound consequences. The patient may receive the incorrect diagnosis or the wrong treatment, which could result in injury or even death. There were guidelines issued in 2010 by the Joint Commission that indicates that at least 2 patient identifiers must be used to correctly identify a patient before drawing any blood. Although 2 patients in a hospital may have the same name and even the same date of birth, they will not be assigned the same ID number. So the ID number must match the number on the requisition. You may be required to ask for other confirmatory information, such as a picture ID, so you need to make sure you check your institution's policies. To greet and identify the patient, you're going to knock gently before entering the room. You're going to say that the physician has ordered the test without discussing any specifics. You're going to ask the patient to state his or her full name and full date of birth. You're going to check the requisition or labels against this patient provided information and make sure that it matches. And you're going to double check on the ID band as well. You're also going to want to ask the patient if he or she has had blood drawn before, because this may be something that they are not aware of what's going to happen. So as far as going back to without discussing specifics of the testing. So what that's referring to is we can tell them what we're drawing, if it's a CBC or a CMP or something like that, but we're not going to tell them why it's being drawn. Okay, that is not our place to try to interpret why the physician ordered these tests for the patient. That is when you would say, I know we're doing a CBC, CMP, but you would need to check with your nurse or your doctor to understand why it's being ordered. So once again, that is not our place as a phlebotomist to be trying to interpret why they are ordering what they're ordering. And then you're going to position and prepare the patient. So you're never going to draw blood from a patient sitting on a high stool or standing, because there is always that chance that somebody could faint or fall over. Outpatients can be seated in a special chair with arm support. For inpatients, you may need to lower a bed rail for better access, but if you do that, you are going to have to remember to raise it again after you're done, because that could raise the risk of the patient falling out of the bed. You're going to support the arm for venipuncture under the elbow with a pillow and ask patients to remove foreign objects from their mouth. Just in case they do faint, we don't want anything in there that could cause a choking hazard. Once we get them positioned and prepared, we're going to explain the procedure and make sure we get that verbal consent from the patient, where you're going to explain to the patient that he or she will feel a small poke or pinch and should remain still throughout the collection process. When you are performing a venipuncture, hand hygiene is important, and then after that you need to put on gloves. You're going to apply the tourniquet about 3 to 4 inches above the puncture site, and do not place any over any open sores. To apply the tourniquet, you're going to tie it. You're going to hold one free end of the tourniquet close to the patient's arm, crossing it over the first on top of the arm, forming an X. You're going to pull the lower side of the tourniquet tight and grasp the X between the thumb and the forefinger of one hand. With the other hand, you're going to tuck in the upper strip close to the X by sliding it under the other side from the above, and then both free ends should be away from the puncture areas. So it takes a little bit of time, honestly, to figure out how to do a tourniquet appropriately. So you will get time to practice that. So no need to worry there. But just know that you may not get it on the first try. So the tourniquet should not be on the arm for longer than 1 minute. An improper tourniquet application can cause hemoconcentration, which is an increase in the ratio of formed elements to plasma. It could cause hemolysis, which is the destruction of red blood cells, which can alter test results. And it could cause petechiae, which are small red spots that are on the skin that could be caused by a tourniquet that is too tight. So both hemoconcentration and hemolysis can cause test results that are not correct. The arm should not turn red and the fingers should not tingle, and you should continue to be able to feel a radial pulse. If the arm starts turning red and the fingers are tingly, it's on too long and probably too tight as well. Selecting the best site. So the best site for a venipuncture is that median cubital vein. That's going to be your first choice. As you can see in the picture there, it's right in the middle. It's a nice, on this diagram at least, it's nice looking, right? That's the one you want to go for. The second one is going to be your cephalic vein, and then your third choice is your basilic vein. You are going to palpate the vein to try to locate it. Trying to locate a vein is best by palpation. Or feel rather than by sight. You can see a vein sometimes, and that may not be your best choice once you touch it. Once you get to your clinicals and you're feeling around on veins, you'll know what I'm talking about when I'm saying it's bouncy. It's going to feel spongy. It's not going to be hard, and you'll know what I'm talking about. You also do not want one that is pulsating because that could be an artery. Tendons can look like veins as well, but they are rigid and they don't spring back like a vein will. If you have difficulty locating the vein, you can increase the circulation by gentle massage of the arm where that vein is located, or by asking the patient to make a fist. All right, so cleaning the site and getting your equipment ready. So you are going to use 70% isopropyl alcohol or another antiseptic that's going to clean the area in circles. So you're going to allow the site to air dry for maximum bacteriostatic action. You do not want to blow on it to dry it. And if you need to repalpate the vein, like retouch the vein, the area must be cleaned again before the venipuncture. So as that site is drying, you're going to assemble the rest of your equipment and get it ready. As you become more proficient in routine venipuncture, removing and reapplying the tourniquet will become unnecessary because you will be able to locate the vein, scrub and dry the site, inspect the needle, and insert the needle within 30 to 60 seconds. So right now we're saying put the tourniquet on, find the vein, take it off, get everything ready, put the tourniquet back on. What this is saying basically is that eventually, once you get proficient at it, you will be able to put the tourniquet on and do all those steps within 30 to 60 seconds. So that's that. You're going to uncap the needle and you're going to examine it for any defects, so make sure it looks like it should. To perform the venipuncture, you're going to anchor the vein by gently pulling the skin tight with the thumb of the non-dominant hand. You're going to hold the needle assembly with your dominant hand with the tube inserted up to the line on the adapter. So the best way to grasp the assembly is with your thumb on top, your index finger close to the front of the holder, and your other fingers gently grasping the underside. Placing your fingers too far forward can elevate the tube holder beyond the ideal angle. When you are inserting the needle, you're going to insert the needle bevel up in one smooth, quick motion. You will feel a slight give when the needle enters the vein, and you're going to hold that needle assembly steady. So it helps to rest your hand on the patient's arm to keep it steady. You're going to keep the assembly angled downward to prevent backflow of blood into the needle from the tube. All right, so you're going to fill that first tube. You're going to push in the tube with the hand that anchored the vein, using your thumb to push that tube in. Be sure to pull back with your fingers on the flanges of the adapter to prevent pushing the needle in further. You want to make sure that you're not pushing too hard because you don't want the needle to go all the way into the patient's arm, right? So to make sure you will be able to clearly see blood as it flows into the tube, insert the tube with the manufacturer's label facing down. Then you're going to advance the change in tube. So this means that you're taking one tube off and putting another one on. So you're going to remove the tube when the blood stops flowing into it. You're going to gently pull the tube to remove it, and it helps to push against the flange of the end of the holder as you do. It just kind of helps keep it steady. If the tube contains additives, you're going to mix it by gently inverting it the number of times specified by the manufacturer as soon as it is removed. So some of those need that 3 to 10, 3 to 5 inversions after you draw it to make sure all those additives are mixed in with the blood. And then you're going to remove the tourniquet. So the tourniquet may be removed after blood begins flowing into the first tube. The tourniquet must be removed before the needle is removed from the vein. Pull on the free short end to release it from the patient's arm. So if the blood flow is slow or collection of all tubes will be complete within 1 minute, the tourniquet may remain on the arm, but it still needs to be removed before you take that needle out. Preparing the needle removal and withdrawal the needle. So prepare for needle removal. You're going to remove the last tube before removing the needle to prevent blood from dripping out of the needle because it'll still have that suction on it if you keep the tube connected to it. To withdraw the needle, you're going to pull the needle straight out of the patient's arm and activate that safety feature. You're going to apply a gauze square folded in quarters generally to the puncture site, and that will help keep the blood in where it needs to be. The patient's arm should be straight or slightly bent, but not bent back up over the puncture site, which can cause a hematoma. All right, so dispose of entire used needle collection and label the tubes. So dispose of entire used needle collection. So basically what that means is you're going to use the disposal method and container that is designed for this type of needle you are using, which is usually a biohazard puncture-proof container. You're going to label the tubes at the patient's bedside or at the patient's side before they leave. You're going to use a ballpoint pen or a permanent marker to identify what time you drew the sample, and usually your initials too, to indicate that it was you who drew it. You're never going to label that tube before you collect a patient. So do not leave the room, as mentioned, without labeling the tubes, and don't let the patient leave the room without labeling the tubes either. The label must have the patient's name and ID number, the date and time of collection, and your initials or ID number. If you are using computer-generated labels, make sure that the label has all the required information and then add your initials or ID number and date and time of collection. Make sure you attend to the patient. So make sure you check that puncture site to make sure the bleeding has stopped or it's not going crazy. Dispose of all contaminated materials in a biohazard container and place all specimens in either bags or tube holders, and then remove your gloves and wash your hands, and make sure you always thank that patient. Nobody's usually super excited to get their blood drawn, so make sure you thank them. In some inpatient situations, it is appropriate to report to the nursing station that you are finished with the patient as well, so you'll kind of learn depending on your facility if that's needed or not. And then you're going to deliver the specimen. So you're going to follow your laboratory's policy about recording your work in the computer logbook or other tracking system. And then you're going to log in the system specimen arrival time in the logbook or computer. So routine venipuncture with the syringe is going to be very, very similar to the regular venipuncture with the vacutainers. So you're going to follow steps 1 through 8 and then 10 of the procedure. So the only one that's really different is filling the syringe. So you're going to fill the syringe. The difference is you're going to use a syringe as noted, but you're going to pull back the plunger evenly, gently, and slowly to withdraw the blood. If you go too fast, you can cause hemolysis of that sample and the patient will need to be redrawn. So make sure that you are not pulling too hard on it. Be sure to firmly brace the hand holding the barrel against the patient's arm so that only the plunger moves, because once again, we don't want that needle moving around in the patient's arm. So unlike the evacuated tube, the syringe does not automatically fill with blood. So it's up to us to gauge how hard we need to pull back. Patients with fragile veins may need to have a blood drawn using a syringe because the stronger vacuum of the evacuated tube could actually collapse their veins. A small needle is usually used for the draw, and then after the blood is drawn, the needle safety shield is activated just like in the regular blood draw. The blood is then transferred to an evacuated tube using a needleless blood transfer device. Routine venipuncture with the syringe. So once again, it's the same. You're going to remove that tourniquet. You're going to withdraw the needle and transfer the blood to evacuated tubes. So you're going to follow step 16 of procedure 9.1 in your book. You're going to activate the safety device. You're going to transfer the blood with the transfer device, which will show you in clinicals. And then you're going to place the tubes in a tube holder. You're going to dispose of the syringe and transfer device together in the puncture-proof container. And then you're going to do hand sanitizing and removing your gloves as well. Again, routine venipuncture with the winged infusion set. It's going to essentially be the same as the other ones. It's just going to be a different needle type.